Hi, good afternoon, everybody. Welcome to this month's Antibiotic Stewardship program. I think it's a pretty interesting topics today. And so if you have any questions first before we get going, if you have any questions about a patient you may have or an issue, you can talk now or later. So, Troy, don't mind getting the slides up.
Well, let's see, just a second here.
Right.
Does anybody have any cases or questions or anything that they want to talk about real quick before we move on to the talk? Anything interesting going on out there?
Maybe after the talk, I'll have a lot of questions.
Okay.
All right, so before we get to the more serious stuff, I thought I wanted to present this case. Probably the only thing you'll remember today. This was printed in this week's New England Journal. It's called Oropharyngeal Tularmia from freshly pressed grape must. So tularemia is an infection from exposure to rodents, rats, stuff like that, and you can get it if you're a hunter and you're skinning an animal, or if the rodents urinate in the water, or tick bites. Okay, and so it's mostly outdoor people, hunters who get it. It can be various presentations, and we'll talk about this one. So this was a German winery, and what they did was, for one reason or another, I don't know why, they hand-picked one bunch of grapes, and they had another bunch of grapes which they used a mechanical harvester for. Probably just cuts it down like a machine cuts it down. So they had the grapes, the grape lots, the hand-picked ones and the mechanically harvested ones were separately pressed. And apparently, for whatever reason, the workers taste the what's called fresh must of the grape after it's pressed. And so 6 of the 8 workers who tasted the mechanically harvested, so it was machine harvested grapes, tasted only the mechanically harvested one. They didn't taste the hand-picked lot. They all developed oral tularemia. They got very sick, had oral complaints and fever and chills. And when they looked at the wine, which was mechanically harvested, they found the DNA of Francisella tularensis, which was found in the mechanically harvested wine. But the other batch, which was hand-picked, they found none of it. So then they looked at this wine. They found rodent DNA in the mechanically harvested wine. So obviously the machine, when it was cutting the grape, also threw some mice in there. So
no rabbits?
Or rabbits, that's a good question. Nothing beats a cool glass of freshly pressed wine, they wrote it. I think you can get that at Trader Joe's. Anyway, so.
That's a bad infection.
It is bad. I mean, do they what's it called, pasteurize wine? I mean, I don't know what happens to wine when they press it.
I don't know.
I don't know either.
They just bottle it?
I've never been concerned about wine before. Does alcohol not kill it?
Obviously not. Anyway, so that was just something to think about next time you have a glass of wine.
We had one. Do you remember that case of tularemia we had about 10? It was when I first hired on about 10 years ago.
Yeah. Oh yeah. And then I had one, I think, first or second year I was here.
Well, I haven't seen a case. Anyway, so let's go on. That was just whet your appetite. So this is more seriously. This is a really interesting article that Jason Gallagher, who's a well-known clinical pharmacist, he had tweeted about this, saying that he thought this was really interesting. He was applying it. And this was an article came out last week, and it's called Microbiology Comment Nudge. Microbiology Comment Nudge improves pneumonia prescribing. And what this is from the Henry Ford Hospital. And what they were finding is, like many of us find, is that vancomycin and zosyn, or cefepime, is often used for both community-acquired and healthcare-associated pneumonia when they get admitted. Obviously, vancomycin is not probably indicated for community-acquired pneumonia, but it is. If you look at the guidelines, a lot of people, it says healthcare-associated pneumonia. Anybody who's been exposed to the hospital system the last 3 months should be started with vancomycin. So because of those guidelines, and up to 70% of people with, quote, healthcare-associated pneumonia are often placed on vancomycin, and about 20% of people with community-acquired pneumonia are put on vancomycin. And so they were very concerned that, these drugs are being overused and not when they're indicated. And so what they did was they wanted to see what happens once people start the vancomycin, and then it comes back, 2 days later, 3 days later, that their sputum is called a normal flora. And so they got a baseline 6-month period, and they saw patients who were on vancomycin who were then reported as normal flora. And they wanted to see how long it took, or if ever, the hospitalist or doctors taking care of them, what's it called? De-escalated the antibiotics that are more appropriate. So then they did that. They had the baseline. They saw how often people did it and what they changed it to. So then they talked to the microbiology lab, and they asked them to do something very simple. Instead of writing just normal flora only, they said, write normal flora only, no staph, no MRSA or Pseudomonas isolated. So all they did was, normal flora, there's no staph, no MRSA or Pseudomonas, which if you read normal flora, you'd normally just assume that, but they spelled it out. And they told the providers, yes, we're doing this simple reporting, that you're going to now see that the reports are showing it's only normal flora and none of these pathogens are found. And so then they wanted to see what happened in the next 6 months. Did this new way of reporting normal flora out, did it change prescribing habits? And so what they found out was that with this, when they adjusted for the severity of the patient, so they basically had comparable patients, that if they put this statement in, the hospitalist or the physician were 5.7 times more likely to de-escalate. And not only did they de-escalate, they de-escalated about 2 days before, quicker than they did before they started the study. Okay, so what they found was that just stating what we assume, that there's none of these pathogens, and that they were able to increase the change of de-escalation, and it was done quicker. And they looked at mortality difference, and maybe there was more mortality. They found no mortality difference, but they did find a significant decrease in acute kidney injury. So Jason Gallagher said this was great. It's a simple thing to do, and he highly recommended it. So we're hopefully looking at doing this at all the hospitals that were involved in the antibiotic stewardship program. But this seems like, everything else is always such a pain to do anything different, but this seems so simple. And I think it would reassure the hospitalist, whoever, that that he can comfortably de-escalate. So that was a really interesting and I think an important study.
We saw this anecdotally with our C. difficile testing. If you
What'd
the
you tell
PCR,
about
so what we and Amy can speak to this too. We added in EIA toxin testing to our PCR testing about a year ago, and we've kind of gone through several variations of how it's reported. First, it was PCR positive, and then if the toxin was negative, it would say toxin negative. But providers wanted to treat that PCR positive result, so then we changed it to, if it was a positive result, it would just say C toxin, and the amount of PCR positive toxin negatives that were treated decreased, at least anecdotally, very significantly. And then we saw the same thing with how the NAP1 result was reported as well. With positive, all caps, people wanted to treat despite the toxin result. Now that the NAP1 result says C toxin, again, we've seen a decrease anecdotally of the number of C. diff colonizations that are treated with antibiotics.
And don't you also say that, PCR positive, toxin negative means patients most likely
Colonized and treatment.
Yes.
Yeah, treatment not
Yeah.
indicated.
So these simple interventions may make a big difference in your antibiotic stewardship program. So that was really interesting.
You remember that study we did just before I left, where we looked at HCAP patients?
Mhm.
And then we treated them as normal CAP if they weren't admitted to the ICU.
Uh-huh.
And we showed that they were discharged 1 day earlier. It was a small study, but we had no problems.
Yeah, so again with the HCAP, they're vancomycin, but that's just if you look at the patient, they're not that sick. I mean, if you've got a MRSA pneumonia, Pseudomonas pneumonia, you're gonna be sick as a dog. You're gonna be on a respirator, toxin. But if your temperature is 101 degrees, you got lobar infiltrates. So clinically looking at the patient and not saying, oh, I have to treat HCAP, can be very helpful in terms of de-escalating and using appropriate antibiotics. So this other study came out in the British Medical Journal, and this is a problem a lot of pharmacists and we all have trouble with, is the risk. They look at the risk of MRSA and C. diff developing in patients who have, quote, a documented penicillin allergy. And so what the Mass General Hospital asks is, what was the risk of these two infections, MRSA and C. diff, developing in patients given non-beta-lactam antibiotics due to a reported penicillin allergy? Because patient says, I got a penicillin allergy. Okay, so instead of using a beta-lactam antibiotic like cefazolin or Zosyn or something else like that, you oftentimes have to pick alternative drugs. And they commented that up to 16% of patients states they are penicillin allergic. But studies done by allergists, however, show that 95% of these patients are actually not allergic, whether the allergy went away, whether it was really a side effect, they got nauseated and they're calling it an allergy, whether they had a viral exanthem like mono with their illness, etc. So identifying patients that are not penicillin allergic can be very helpful. And because of this, if you say you're penicillin allergic, oftentimes you use broad spectrum antibiotics leading to drug resistance and toxicity. So in this large study, they found that using alternative drugs, and really the bad actors, as we'd expect, were the macrolides, clindamycin, and the fluoroquinolones, the risk of somebody developing MRSA because he had a penicillin allergy and an alternative drug was 1.69 for MRSA and 1.26 for C. diff. So again, this takes a lot more effort, but addressing, quote, penicillin allergies may be an important public health strategy and in the hospital to reduce the risk for C. diff and other MRSA developments. But that's usually the old headache. You have to go in, and hopefully the pharmacist will go in and say, "What is your allergy?" And so, my mother told me because Uncle John had a penicillin that we all should avoid, penicillin. All right, so those are some interesting articles. So, 2018 update on the fluoroquinolones, and really, this is not a joke. Use at your own risk. If a problem develops on a quinolone antibiotic, you are basically setting yourself up for being sued. All right, so I want to review some of this in 2016, and now there's a lot of updates and a lot bigger warnings and that have come out. And so just remember the Fluoroquinolone Generations. If you're old enough, like me, I remember Neuroxin, which was the first one came out. It was the oral treatment for urinary tract infections. But the big ones that we use now are ciprofloxacin, which gave you, it was orally absorbed, well absorbed, and gave you Pseudomonas coverage. Then you got the respiratory quinolones, levofloxacin, which was a derivative of the old ofloxacin, now gave you pneumococcal coverage, the third generation, and then the fourth generation, moxifloxacin, add anaerobes to it. So basically it was similar to like a Unicin or something like that. Very give you activity against anaerobes. So really the three that we talk about mostly are Cipro and Levo and moxifloxacin, sometimes you see, but Cipro and Levo are both generic, and so they're the ones mostly prescribed. Okay, so if you remember about 2 years ago, the FDA came out with warnings, and you may be familiar with these potential fluoroquine side effects. One, as we've seen over and over again, the quinolones increase the risk for C. diff colitis. They develop resistance in the Clostridium, and the drugs don't work, and leads to C. diff very frequently. The other big one is acute tendinitis, where you can get a rupture of your Achilles tendon, particularly at any time, early or late, when you're on the fluoroquinolones. There are QT prolongation issues. It can cause torsades. I usually don't think about it, but then the pharmacist says, if his QT is 0.6, you better not give it to him. And then there are central nervous systems and peripheral neuropathy. But most of us are aware of these risks. And so the FDA made a point back in May 2 years ago. They say serious side effects associated with fluoroquinolone antibiotics generally outweigh the benefits for three particular instances: patients with acute sinusitis, acute bronchitis, and uncomplicated UTIs, if they have other treatment options. Fluoroquinolones should be reserved for those who do not have alternative treatment options, okay? And basically, you should warn your patient if you're giving a fluoroquinolone. So the FDA is particularly focused on sinusitis, bronchitis, and uncomplicated UTI, that we have alternatives, and you should not be using the quinolones up front. So now, this month, the FDA got really cracked down even further. They added additional fluoroquinolone warnings. And what they reported was the risk of hypoglycemia. And they said there's been at least 67 cases of life-threatening hypoglycemic coma, 13 deaths, 9 with permanent, oftentimes comatose for an extended period of time, permanent disabling injuries. These occurred more frequently in the elderly and those with diabetes taking oral hypoglycemic medicine or insulin. And also others who had renal insufficiency as a risk factor. They didn't say why, but maybe it was because the levels go higher when you have renal insufficiency. And they said 4 of these antibiotics already have labeled drug interaction with sulfonylurea. And in their reports, the most commonly was seen with levofloxacin, Cipro was second. Okay, so this was a big warning going on.
Levo was second to Cipro?
These are
First,
just numbers, so
Those are
this
just
could be reflected in the number of, maybe levofloxacin is prescribed more frequently
Okay.
than
yes,
Cipro.
yes. Yeah, they had a few other ones, but these are not the ones we mostly use. So they said not only you have to watch for fatal hypoglycemia in these patients, and it's certainly a risk, particularly in those with diabetes.
Was this over a year, or what was this over the time?
This was second.
Probably MedWatch reports would be my guess.
Yes.
So probably for the life
Whatever.
they've been out on the
I'll
I'm gonna
market,
try to go back.
Yeah.
Oh, okay.
Next one.
my guess.
Yes. Next. So that.
Oh, sorry.
Oh yeah. All right. So this was the FDA went crazy about hypoglycemia, particularly in diabetic patients and the risk of coma and death with these drugs. And then they did this. They updated the psychiatric side effects, and they wanted a new labeling. And they made, apparently the labeling was not consistent. Some quinolones would be associated with certain CNS side effects and others. And now they wanted these to be prominent and consistent across all the fluoroquinolones. So we knew about agitation, nervousness, and disorientation are already listed, but they added 3 new ones: disturbances in attention, memory impairment, and delirium. And I think some of this is thought to be irreversible too. Do you know much? So
Really?
they,
I heard that.
yes. So they really have added, you have C. diff, you have Achilles tendonitis, you have QT prolongation, you have potentially deadly hypoglycemia, and now you have severe neuropsychiatric problems. And the FDA is making these big black box warnings. All right, so just to review, the diagnosis, we talked about uncomplicated cystitis again. As Dr. Hooten talks, he's a urologist, sort of expert in the New England Journal, wrote an article saying, don't treat asymptomatic bacteruria, okay? There's no reason to treat asymptomatic bacteria. Treating asymptomatic bacteria doesn't reduce the risk of pyelo or UTI developing. It doesn't reduce the risk of almost anything. It doesn't improve diabetic control. But he says, when you diagnose cystitis, you want to go on the basis of symptoms only. And the only 2 symptoms or 3 symptoms are dysuria, frequency, with no vaginal discharge or irritation. And there's some evidence now as much as 95% chance that women who have these specific symptoms have cystitis, okay? A dipstick is going to miss some of the cases because you're going to have cystitis with very few white cells. And culture will pick up greater than 100,000, but most bladder infections may have only 100 to 10,000 colonies, and the way it's reported maybe it's only 1 to 10 colonies by the microlab because it's 1/1000th of the number of colonies. So again, Hooten just reinforces only treat patients who have symptoms, okay? Not because they're confused, not because you find it under admission your analysis or anything else like that. Don't treat it. So really focus in on when you treat uncomplicated cystitis, just treat patients with symptoms.
Treatment can actually increase the rate of infection because
Correct.
some of these bacteria are actually protective.
Yeah, we've talked about that before. Yeah, you're wiping out the protective bacteria and you're setting yourself up for pathogenic E. coli and the other complications. So the goal of treatment of urinary tract infection is to ameliorate symptoms. It's not to do anything else. Obviously, if you're a pregnant woman or somebody's going to have a prostate biopsy, that's different. And so what antibiotics should we pick, okay? This is from Washoe County, and I also think Renau is very similar. You know, macrodantin, which doesn't cause C. diff, it's urinary excreted, it really doesn't upset the bowel flora. 98% of all E. coli cultured in water are susceptible to macrodantin. So that's amazing susceptibility. Very well tolerated for 5 days. If you look at Bactrim, for 3 days, it's about 75%. Cipro was 78%. And Ceftonir was about 90%. So it doesn't make sense to use a quinolone to treat uncomplicated cystitis when you have better alternatives, okay? Macrodantin or even Bactrim. The other thing about this, maybe a woman comes in and she responds to your antibiotics, so a culture is not being done. So these may actually, Bactrim may be 75%. It may be 75% of urines that's actually cultured. A lot of women may not be cultured because they responded to Bactrim, so you may actually have more efficacy than 75%. But again, the recommendations of renown are what?
Macrobid first line, and then we'd use Bactrim second, and then cephalosporin, either anywhere from Keflex to Omnicef, which is Ceftonir, as third line. Studies have shown that oral cephalosporins are not as effective as Bactrim and Macrobid. So that's our third line.
Yes. I don't hear Cipro on the list.
That's correct.
Yes. Okay. You use these safer drugs. And this was, I mentioned this study before, but I have some more. This was a study looking at uncomplicated cystitis in a large private family practice clinic. So these are well-insured patients. They can pay for anything, or somewhat. And these were women coming in. They had 1,546 visits. And they didn't look at patients who had complicating factors like pregnancy, recurrent infection, antibiotic allergy, or fever. And these providers, 52% of the prescriptions were fluoroquinolone, Cipro, Levaquin. Not only were they more than 3 days of Cipro, 71% of these patients were given 5 to 10 days of therapy, and only 29% were recommended for 3 days. So the drug of choice in these family practice, middle-class practices was Cipro, wrong drug, and too long a time. So you're just setting yourself up for trouble. 36% used macrodantin. They were given for 1 week most of the time instead of the 5 days, and 12% used Bactrim, which should be just 3 days. So primary care physicians strongly prefer fluoroquinolones and prescribe longer courses of therapy than recommended in the guidelines. And with these side effects coming out, I would probably don't recommend it. This came out this week. This was Clinical Infectious Diseases. Opportunities to improve fluoroquinolone prescribed in the U.S. for adult ambulatory care visits. And somehow this National Ambulatory Medical Care Survey was able to look at all the prescription of antibiotics across the country, and this was 2014. They had 31.5 million quinolones were prescribed. Approximately 25% of these were given either for viral URI or bronchitis, which, as I mentioned, are not indications that FDA recommends, or not recommended for first-line therapy, such as uncomplicated UTI or sinusitis. All right, so there's a fantastic overuse of these quinolones. And this is what was interesting. This is coming out in JAMA Internal Medicine. They wanted to look at, this is not just about quinolones, but antibiotic usage, depending on where the care is. So they looked at prescribing of millions of patient visits in retail clinics, I say probably like a minute clinic, urgent care clinics, emergency departments, and traditional ambulatory care settings, like in a physician's office. The CDC funded the study, and then want to look at prescribing patterns. So they want to look at prescription rates by care setting for visits for antibiotic inappropriate respiratory diagnoses, viral URI, bronchitis, asthma, non-suppurative otitis media, etc. So they just looked at the same diagnosis in all these clinics, and it ranged from urgent care centers, 45% were getting antibiotics, emergency departments, 25%, medical office, 17%, and retail clinics, 14%. And so these were all probably, most of the time, were unnecessary prescriptions, but the same diagnosis, you can see how there's such a variation in care. You don't know, maybe people, the provider figures if somebody's paying $100, they're gonna want a prescription for something. But the conclusion was that unnecessary prescribing practice in outpatient settings likely to exceed reported 30% of all dispensed antibiotics. So again, we were talking at the infection control the other day. While we're really tight on controlling antibiotics in the hospital, the large majority of antibiotics are given in the outpatient setting. And those are the patients, much of the time, are coming in with C. diff or at risk for C. diff. So, we can we can try to control the hospital, but it's the outpatient settings that the primary providers that are overusing antibiotics. All right, so these were some of the guidelines for management of acute sinusitis, one of the indications that the FDA should not use the quinolones first. And they're, they should be symptomatic more than 10 days, severe symptoms, purulent nasal drainage, and fever worsening symptoms. So the recommendation is Augmentin first, Doxy, and Levaquin only as an alternative, and that no more than 5 days should be adequate. What are our, we just came up with guidelines, right?
Yeah, ours are, it's Augmentin and Doxy, and then Levaquin is only in recurrent cases where they can't use the high-dose Augmentin XR.
Okay. And they just say, do not use azithromycin given high incidence resistant strep pneumo. Okay, so we looked at UTIs, macrodantin, Bactrim, oral cephalosporins, acute sinusitis, Augmentin, and Doxy, if these patients even need these antibiotics. So this was a patient we had a few years ago, 56-year-old female with asymptomatic bacteruria. She came in for a pre-op evaluation prior to elective hip replacement. She noted on the urinalysis to have bacteruria in a positive culture, but no symptoms. The surgeon prescribed a week of ciprofloxacin, completed a day before surgery. So first of all, there was no reason to check her urine. Second of all, she had no symptoms. And third of all, he used Cipro. And if he was supposed to use Cipro, which was not even on the list, it should have been for 3 days. And so she had a successful surgery, but she was readmitted the next day with fulminant C. diff colitis and died. Right? And this was a 77-year-old male with, quote, penicillin allergy and a dog bite. 4 days prior to emergency room visit, bit in the part of his hand when separated 2 dogs. Came to the ER complaining of progressive onset redness and swelling of his hand and arm. He was given oral levofloxacin, 750 a day for 5 days, and a week later developed severe unilateral Achilles tendonitis. Definitely you want to treat, find out what the allergy is, but definitely you want to treat, Pasteurella as a possibility, but you could use Bactrim and other options. So, or 3rd generation oral cephalosporin. Again, these drugs are toxic. So what's online for patients to view? You got the hysterical family up top and you got the happy lawyer down. So this was a, oh, sorry. Can you go back to that?
Can you play the link?
Oh, yeah.
Doctors offer for everything from urinary tract infections to sinus infection.
Levaquin off the shelves.
Prescribed antibiotic. Doctors offer it for everything from urinary tract infections to sinus infections.
But a local mom is pushing to get Levaquin off the shelves after she says she suffered devastating side effects. And a drug watchdog group is pushing the FDA for tougher warning labels. NBC Charlotte reporter Michelle Bowden has the story, and it's all new tonight.
Shannon Myers is trying to slyly wrap his Valentine's Day gift for wife Adrian. The two are a team no matter what.
Every day, you push through it. You push through it because you have to.
Adrian endures grueling physical therapy several times a week.
That left one is still so sore.
The 36-year-old mother of 2 struggles to walk.
It's very painful for me, just because my Achilles hurt really bad. So in order for me to not lose strength in my legs, I have to do this, I just have to bear the pain.
It started last summer. Adrian was diagnosed with a sinus infection. Doctors prescribed Levaquin, the brand name for a drug called levofloxacin. A few days into the prescription,
I started having issues with my legs. My legs hurt, they burn, they feel like I walked uphill all day. My feet hurt. I had problems with my eyes, my vision started becoming kind of blurred.
It took 3 months and 4 doctors to come up with a diagnosis.
Let's put a timeline to this and see where we are, and then see if we can kind of tease out any correlations. And that's really where we were able to sort of get to the notion that, hey, this was a Levaquin problem.
Dr. Ki Jung, Adrian's neurologist, says the Levaquin caused tendinopathy and peripheral neuropathy.
He said, unfortunately, you have nerve damage from taking Levaquin.
I'm not surprised. I've been thinking about this and working on this for years. This woman is a story that's replicated in city after city, in case after case I've read.
Dr. Charles Bennett chairs a drug watchdog agency at the University of South Carolina. He recently petitioned the FDA for new, what's called black box warnings for Levaquin. Those are bold warnings meant to grab your attention. The FDA already required black box warnings in 2008, warning of possible tendon rupture and muscle weakness. And in 2013, the FDA required a label change warning of nerve damage. Bennett says the FDA's own stats show 1,200 people have died and nearly 100,000 have suffered side effects from Levaquin or levofloxacin.
I'm very fortunate that it has not been a life-threatening thing for me, and so I just think about positive, and hopefully my nerves will regenerate themselves and become healthy again.
Makes you wish, just like anybody you love, makes you wish you could go back. Do something about it, maybe.
In Charlotte, Michelle Bowden, NBC Charlotte.
Now the company
makes Levaquin emailed us this statement saying that
Last slide. All right, so bottom line, there's growing medical and public awareness that the fluoroquinolones are potentially toxic drugs. New serious toxicities are still being identified. Highest risk patients, particularly for hypoglycemia and neurologic problems, are elderly patients on treatment for diabetes, have renal insufficiency, and we know also PPI use and hospitalized patients are at increased risk for C. diff. The greatest overuse of these drugs are in treatment of uncomplicated UTIs and asymptomatic bacteruria, both in using them in the first place and then prescribing them for a long course of treatment and indicated. Should also not be first-line treatment for sinusitis or acute bronchitis. And it would be difficult to defend the fluoroquinolone prescription in court if prescribed outside of guidelines and a serious complication develops. I would take this very seriously. And so try to avoid them if you can.
So one of the conversations that I routinely have, and I'm curious to get your opinion, is the hospitalist and the patient with, like, say, an E. coli bacteremia being discharged. It's either continue their IV cephalosporin as an outpatient in the infusion center where they have a PICC line, or go home on oral Cipro. But I'm really scared about the Cipro black box warning. But
that FDA doesn't talk about that. Okay, that's an excellent indication. There's risk of IV therapy, and so I would think that's a reasonable choice. Does she want to be stuck in a nursing home for a week getting IV antibiotics and PICC lines and getting C. diff?
And at risk for line infections. And that's the conversation that's how I lead or address the conversation.
The FDA doesn't question that at all. It's just when we have alternatives, treatments, or we shouldn't even be using antibiotics in the first place, like UTI, sinusitis, bronchitis, the quinolones should be used. So there's definitely a role for the quinolones, but it's a risk-benefit.
Was it resistant to Cipro?
This was hypothetical, but I get the conversation fairly often.
And so the other thing is look at your antibiotic, your microbiology lab, see how they're reporting it. But I think the idea of just simply adding no MRSA, Staph aureus, to Pseudomonas will probably make the hospitalist, whoever's taking care of the patients, much more comfortable in de-escalating. Because a lot of times, patients on vancomycin, they say, yeah, I see the sputum's negative, but the patient's doing well. I don't really want to rock the boat. And particularly in intensive care units where the doctors don't know them, they're changing physicians all the time. So this, I think, could help them if you educate them that you can stop the antibiotics, okay? And it's been studied, and all it does is have less toxicity. So I think that's something people should be looking at too. All right, I hope that is helpful.
Yeah, any questions or anything out there?
Or comments?
I didn't know that some of the CNS problems were irreversible.
All right, well, thank you very much.
Thank you, guys.
Thank you.
Thanks, everyone. We'll be back.
And have a glass of wine to relax. German wine.
With some Doxy.
We can only drink hand-picked wine now.
You're the wine snob.